Hello, I'm your professor, Randy Kearns, and I'll be spending a little bit of time this afternoon going over hospitals, home health, and ambulance. Um, and obviously, this is for the week of March the 24th. Let me change my screen sharing to this so that you can see. Okay, so that should be a little bit better. Let me also be sure and say that there's two assignments this week. The first assignment is a quiz. It's based on the content in this presentation. And I doubt I'll get through all of the presentation in the time allotted, but I do want to be sure and hit the highlights of it because it is kind of a lengthy presentation. The second piece is, aside from the quiz, there's also an online discussion. Part of this is to also be sure and talk a little bit about the history of some emblems that you may see and what some of the differences are. So without anything further, let me go ahead and start with, first of all, the universal symbol for the hospital is typically a blue field with a white H on it. And if there is additional signage, it may be denoting that it's a trauma center. I've also seen signage where if the emergency room is closed after midnight, it may show limited hours for the emergency department. Obviously, that's in a little bit more rural areas, but maybe something that you will see. And so let's kind of pivot into a couple of symbols that quite honestly, somebody probably got mixed up at some point, but the image on the left is the caduceus. The caduceus is the staff of Hermes, includes two snakes that are intertwined with surmounted wings. The challenge with that is, in Greek mythology, that symbol is associated with commerce, theft, deception, and death. Somebody probably intended to recall the rod of Acelpheus, and the image on the right is actually what that is. So there will be times that you see both emblems and somewhat interchange. Just understand that they, if you look at their origin, Greek mythology, they have two completely different meanings. Nevertheless, a lot of times, and I've also had someone tell me that the one on the left is associated with allopathic physicians, and the one on the right is associated with osteopathic physicians. The truth is, medicine is associated with the one on the right. Again, Acelpheus was the son of Apollo, and also the god of healing. Acelpheus had daughters. One was named Hygeia, another one's named Panacea, goddess of hygiene and cleanliness, and the goddess of remedies. And obviously, Acelpheus, Hygeia, and Panacea are more the family that we link their symbolism to symbols that have been used in healthcare through the last 2,200 years. Anyway, let's kind of move on. And one last thing, just understand the Acelphian snakes were seen as actually associated with good health, but I don't. That would not be a personal opinion. That's just something from the material that's out there. So let's kind of talk about our next emblem, and this is the emblem that we most commonly associate with emergency medical services. They've incorporated the rod of Acelpheus, as well as a single snake intertwined around the rod, and then a six-sided star. And this is referred to as the Star of Life. Again, it's an emblem that is most commonly associated with emergency medical service or emergency services. Anyway, So as far as key terms go, so I've talked about Celsius, caduceus. Again, the caduceus at some point was probably co-opted, not understanding the difference between the two, but it is widely used, particularly in military medicine. So it is relevant. Just understand there's somewhat of a disconnect if we're looking at Greek mythology as the basis for it. Hygeia and Panacea, and obviously their connection to their father Celsius, the Star of Life, and then some other terms that we use in healthcare that I want to go into as a part of this conversation. That includes what an inpatient is, what an outpatient is, what's the difference between licensed and certified versus accredited. And then again, different types of structures, an almshouse, a pest house, a madhouse. We've talked about those before, but this is a good place for us to bring them up again and reinforce them a little bit. Discharges, average length of stay, census, meaning counting how many people are in the hospital, capacity, how many staff beds are there, what is the average daily census. Those are key metrics that you may need to know if you work in hospital administration at some point in your life. The executive staff, so typically the executive staff is a group of leaders that are, in many cases, their offices may be in the same general area. And that's often referred to as the C-suite. C is in the letter C. And what we're talking about there is the CEO, the Chief Executive Officer, the COO, the Chief Operations Officer, the CNO, the Chief Nursing Officer, the CFO is the Chief Financial Officer, and the CIO is the Chief Information or Informatics Officer. And then the medical staff is led by the Chief Medical Officer, the CMO. And then we want to talk about different types of buildings that provide healthcare, hospital versus a medical center versus a teaching hospital, and then other types of hospitals, public, private, for-profit, general hospital, specialty hospital, critical access, and long-term care hospital. So let's kind of start with hospitals and medical centers. I'm going to start with this image of University Medical Center, which was built to replace Charity Hospital, as you know, one of the oldest hospitals in the history of the United States. And the main point to remember about a hospital is it includes places for an overnight stay. The best way to differentiate between what's certified and what's licensed, if you think about your driver's license, who issued that? The state of Louisiana. So a license is issued by the state, and then to participate in Medicare, meaning I want to bill Medicare for the services I provided, Medicare has to come out and certify my facility, my hospital, to be a participating provider. So I'm licensed by the state and certified by Medicare. And then the other piece there is accrediting, who provides accreditation. And in most cases, there's a private organization called the Joint Commission. They establish standards, and we'll talk about them shortly. So again, licensed by the state, has an organized physician staff led by the Chief Medical Officer, provides continuous nursing services, has a governing body, and ultimately the governing body is ultimately responsible for what goes on at the hospital. Now, they will hire somebody to handle the day-to-day activities, and that's the CEO, the Chief Executive Officer, and the CEO is responsible for operations. And then other things, hospital must maintain medical records, have pharmacy services available, food, nutrition, and therapeutic services, and then construction and operation governed by federal laws and state laws. Again, Joint Commission, that JCAHO is the Joint Commission for the Accreditation of Healthcare Organizations, although today we're more likely to call them the Joint Commission. And then medical center is somewhat of a euphemism, but it's a way that we can talk about a large hospital with a wide scope of services. Sometimes I've seen smaller hospitals rename themselves a medical center, and I've seen larger hospitals just continue to refer to themselves as a hospital. So there's no real clear line in the sand, but if you were trying to carve out a definition, hospital is more of a generic term that we use for all buildings that are licensed as hospitals with inpatients and outpatients, and have a pharmacy and have a medical staff and have a nursing staff and some of the other things that we just talked about. But a medical center is typically a large comprehensive hospital with other services being provided. But as I say, I've seen much smaller facilities call themselves a medical center. There's no clear distinction on where that line is. An almshouse, so we've talked about this before, but the almshouse was typically that charitable place where older people went to live, and may have included a hospital, but we were far more likely to call them the old folks home, and they would go to the almshouse. You know, what dramatically changed all of that was the creation of Social Security. Before Social Security, you either went to live with family once you got older and couldn't care for yourself, or if you didn't have any family, you became a ward of the state. And that's how some of these institutions were created, again, referring to as the old folks home, and primarily known as an almshouse. And then again, the evolution of the hospital in the United States. There were very few before 1850, although I will say there were several in New Orleans at the time. Touro was certainly one of the first hospitals in the United States, and the Charity Hospital of New Orleans was the first of two hospitals in the United States, and had continuously operated until 2005, when it was closed following Katrina. One other, so we talked about an almshouse, also referred to as the poorhouse. A pest house is a place, if we set up a quarantine hospital and we put all of the sick people in this building, that's typically what's referred to as a pest house. You may also, I may have it here later, but there's also a French word that we use for a pest house, where again we put a lot of people who are sick. Actually, quarantine is not the word for that. It should be isolation. If you're ill, it's isolation. If you've been exposed but aren't necessarily sick, then it's quarantine. But anyway, a pest house, the French term for that is a lazaretto. Lazaretto, lazaretto. A lot of hospitals early on were either a function of government, or if they were community institutions, they were maintained through private charitable donations. The Charity Hospital of New Orleans is a great example. It was established through someone's will who had died, and he wanted to build a hospital as his contribution back to the city that had given him so much. And then the Catholic Charities stepped in and provided a lot of the manpower for Charity Hospital. And then other pieces include understanding how disease was transmitted through germ theory, laboratories and x-rays. The more we understood how these things occurred, some advanced sanitation that really came into being during the American Civil War. There was a nurse by the name of Florence Nightingale who was a courageous champion that had witnessed some of the atrocities during the Crimean War, and recognized that one of the most important things in getting people healthy included cleanliness, and hospitals in the 1840s, 1850s didn't exactly embrace cleanliness. Anyway, and a lot of the smaller hospitals were physician-owned, and that was more of what we saw even after the American Civil War up until the 1930s. But we'll talk a little bit more about that transformation later. And then some of the larger hospitals certainly began as university affiliations. They needed a place for their students to practice medicine. Research was certainly important. And again, they became far more complex organizations. And as markets begin to merge and consolidate, particularly over the last 20 years, we've seen some huge healthcare systems form as a part of that. You know, we have 4 very large healthcare systems all represented in the greater New Orleans market. 2 that we don't really think about. Tulane is a part of Hospital Corporation of America, HCA, which actually is the largest owner and operator of hospitals in the world. And then the VA healthcare system is also a very large organization. And, you know, although, again, there's a large hospital here, that's far from, you know, all of the healthcare services they offer. You know, the 2 you primarily think of is LCMC Health and Ochsner Health, which are in and of themselves very large and formidable organizations. But it is important to point out we have 4 very large healthcare systems based in, at least with connections to the New Orleans area. And then expansion and downsizing of hospitals. So hospitals grew significantly until about the 1930s. And what happened in the 1930s was a global economic recession. There were a number of hospitals that financially just struggled to stay alive through the Great Depression. And then war began with World War II. And then in the aftermath of World War II was passage of the Hill-Burton Act of 1946, which really had a huge impact on how hospitals were built, how many hospitals were built, to the point that quite honestly, by the 1970s, we had over 7,500 hospitals in the United States. And today we have about 5,400, which gives you an idea of just how many more that we had than we really needed. So we kind of went from not having enough to probably having too many hospitals for a while. Medicare and Medicaid also, again, provided a constant flow of income, but Medicare and Medicaid changed healthcare in some pretty dramatic ways. One other aspect of Medicare and Medicaid that isn't often written about is the importance of the non-discriminatory clause. Before Medicare and Medicaid became law, there were separate entrances for people of color. There were, at least in many parts of the United States, there were different locations for where people could eat. There were different wards, again, for people of color. In some cases, physicians of color could not practice in the hospital. It was predominantly whites only. Medicare and Medicaid ended all of that. And the way they did it was they basically said, look, you can continue doing what you're doing, or if you want to take our money, this is what the rules are. The rules are non-discrimination. You know, whatever the entrance is the entrance for everybody. Whatever the eating requirements or eating opportunities are in the cafeteria is for everybody. There's no limitation in how people become permitted to practice medicine, other than they're a graduate of an accredited medical school. So anyway, Medicare and Medicaid did a lot to fund and fuel the cost of healthcare, but Medicare and Medicaid also made some subtle but very significant changes in what we saw in healthcare in the early 1960s and what we saw in healthcare by the late 1970s. So a part of the expansion and downsizing, part of this change was triggering the prospective payment system. implementation of the diagnostic related group, a lot of transition from inpatient care to outpatient care, managed care emphasized, early discharges, and a lot of outpatient services. A lot of that was to, again, further economize the healthcare system. And we've had ebb and flows of when we tried to economize the healthcare system, and some of those cases worked. Key measures that we use to help us understand productivity includes access to care, being sure that people have adequate access to care. It's a real limitation in rural communities. It's certainly a limitation in poor communities. A lot of hospitals don't exist in rural communities today and don't exist or thrive in poor communities. And so we look at discharges to help us understand productivity. We look at utilization. One key measure is average length of stay. And let's say we look at everyone who was admitted to the hospital last year with a non-complicated myocardial infarction. And if the total number of those patients are 1,000, and we look at the total number of patient days, how many days did those 1,000 patients stay in the hospital? If the total patient days is 5,000, then 5,000 divided by 1,000 gives us 5, meaning the average length of stay for a non-complicated heart attack was 5. And the whole point to that is, if you know you're going to get paid based on a DRG, if the DRG suggests that if you're averaging 5 days for your average length of stay, but you maximize payment at about 3.5 days, is there something you can do to discharge some of these patients a little bit sooner so that you can squeeze that 5.0 down to maybe not 3.5, but 3.8 or 4.0, because again, we lose our profitability if we stay over 3.5. Now, we may be endangering the patient if we kick them out at 3.5, but what are the good things we can do to provide good, decent care and appropriate care, and yet discharge the patients in a way that's safe and effective for them, but still financially viable for the healthcare system? Certainly an important thing to consider. It is important to note that in a lot of studies, there's no evidence that quicker discharges from the hospitals have harmed patients, but there are times that that's the case, and particularly with readmissions. And although broad studies have not shown that harm, there are small isolated cases where it has, and so that's a part of the readmission reduction program that we talked about in the pay for performance measures. Other numbers that are important: the census is a count of how many patients we have on any given day. The patient days or days of care help us understand what our cumulative census is. The average daily census is the number that I just talked about. Understanding some of these demographics in terms of the elderly, or what we see out of utilization, and then how that helps us understand prediction of utilization, and then how do we take care of that patient population. Let's see. 84% of community hospitals have fewer than 300 beds. What that really tells us is, although again, we have several very large hospitals in the greater New Orleans area, that's not typical. The typical experience is 1 or 2 smaller hospitals, and particularly in rural communities, lucky if you have a hospital with 20 beds, 15 beds, and a critical access type hospital setting. 10% of the US jobs are in health professions. 40% of healthcare workers are employed by hospitals. It's a growth sector. The main point to all of this is to help you understand that it's a huge potential for an employment opportunity, but it's also a significant part of the economy. And then hospital classifications, the public, the private nonprofit, the private for-profit, and then a general hospital. Let's kind of divide those up. And then we also want to talk about specialty hospitals in terms of how they can be divided. The psychiatric hospitals and the rehab hospitals are really very true specialty hospitals. Children's Hospital is a little bit more of a multi-dimensional care type facility, but targeting obviously children. Rural hospitals are more likely to be critical access type hospitals. Teaching hospitals are associated with medical schools. And then an osteopathic hospital, those really don't exist anymore. Again, if you look back in history, you'll see that there were osteopathic hospitals where DOs, doctors of osteopathic medicine, developed a part of their skill set. But again, as I've said before, the DOs and the MDs, the allopathic physicians, both practice pretty similar healthcare. The DOs do take a little bit more of a holistic approach. So, again, depending on which angle you look at will depend on which side of that argument you want to take. But by and large, what we once knew as osteopathic hospitals is pretty much faded away. And then this is the VA hospital in New Orleans. Again, public hospitals, and the most common public hospital is the VA hospital, but there's also a state psychiatric hospital, other government type hospitals that are a little bit less common. If there's a large federal prison, there's a pretty good chance that there may be a federal hospital that's a part of that federal prison. Those are not exactly the type of people you want to take out of prison and take to your local hospital if somebody gets sick or injured. They see that as an escape opportunity. So again, it's not uncommon for very large prisons to have some type of medical care facility on site. That would certainly be a public hospital. And again, public hospitals are typically smaller than what the general hospital or the community hospital is. Here's a couple of Ochsner facilities. The one on the bottom is the Jefferson Highway campus, which, as you can tell, is a very large healthcare system. The one on the top is actually an outpatient facility that was built on Interstate 10 going into Baton Rouge. It has a lot of day surgery. It has a lot of diagnostic services available there, but there's no overnight stay. When I first moved to New Orleans, my wife lived just really across from this facility. And it was really interesting how often we saw EMS respond there to transport someone to a hospital. And that was the point. There were a lot of things that they could do there, but if someone was there and developed some type of a serious medical condition, they would wind up needing to go to one of their inpatient hospitals. And Ochsner has a large inpatient hospital on Interstate, just off Interstate 12. Private not-for-profit, again, this is the most common type of hospital. It's community-based. A requirement for the Hill-Burton Act was it had to be a private not-for-profit healthcare system. And so, again, the point was to provide charity care and to provide care for people who were unable to pay for care themselves. That was a trade-off in accepting Hill-Burton money. Proprietary hospitals are investor-owned. As I've said before, HCA is the largest investor-owned hospital in America. Investor-owned means it's publicly traded stock. It's on the stock market. It's not to say they don't provide good quality patient care. I mean, obviously they do. And if they don't, I mean, they certainly have an obligation to do that. It's just the community-based hospital has an obligation to reinvest their money in the community a private for-profit hospital has an obligation to return shareholder investment, just as any other business does. The people in the for-profit side of the industry will tell you that by and large they provide as good, if not better, quality of care as community-based hospitals. And I've never worked in one, so I can't tell you that I find that to be incorrect or not. So I just don't know. I can tell you that the investor side of healthcare has shaped a lot of the things that we do in the not-for-profit side of healthcare. I can tell you, I worked in hospital administration at the time. The predecessor of HCA was Columbia HCA. And Columbia HCA at one time owned over 320, 330 hospitals in America. They were one of the 10 largest employers in the world. And we hired several people, the healthcare system I worked for, we hired several people from HCA just to give us some insight into what they were thinking. And they had some pretty interesting business solutions for some of the things that we were doing in the not-for-profit side of healthcare. But today, I will tell you, even if you're not-for-profit, a lot of the things you do have been shaped by what the for-profit side of healthcare has done. And that's not always good, but it does maximize profitability, and it does provide some financial stability where in certain cases you've not always had that financial stability in some hospitals. Some hospitals they have service lines that are what's called loss leaders, meaning we know we're going to provide this service, we need to provide this service, but we also know we're going to lose money providing this service. And for every dollar you lose providing a service, you've got to make $2 to make up for the dollar you lost over here and to pay for the dollar's worth of whatever you're doing over here. So it is a bit of a challenge. And again, we have learned to some extent from that. Let's see, what else do we want to talk about? General versus specialty hospitals. Again, a general hospital typically gives us kind of that broad range, broad scope of services that are available. The specialty hospitals really specialize on one particular type of care. It could be an orthopedic hospital. I'm sure there's rehab hospitals in the greater New Orleans area, and there's probably a long-term care hospital or two. Just none immediately come to mind. But again, they primarily have this distinct service niche. The Children's Hospital is really the best example, although they are more of a general hospital, but for the pediatric population of, again, the greater New Orleans area. Psychiatric hospitals, this is actually a psychiatric hospital here in Louisiana. And this is the rehab hospital over at Ochsner. And this is just down the road from the Ochsner main campus on Jeff Highway. And this is also on Jeff Highway. Here's Children's Hospital, I mentioned earlier. Rural hospitals and primarily critical access hospitals, the only advantage they have is they actually have some funding mechanism that allows them to be a little bit closer to break even. It's just very difficult to, healthcare requires a lot of volume, and it's very difficult to generate the type of repetitive volume that you need in a rural healthcare setting. It's tough to recruit people to work there. There was a time that I provided, I was the director of an EMS system in a rural community where the only hospital locally was a critical access hospital. It was actually one of the first critical access hospitals in the country. And they struggled. I mean, they struggled there were times that they had to figure out what bills to pay so they can make payroll. I mean, it was that their margins were very, very tight. The teaching hospitals, Again, we have them here. They exist everywhere. It is an important place for people to learn, and it has to be an effective part of any medical school. And certainly, whether it's LSU New Orleans or LSU Shreveport or Tulane, those are three. There's actually a fourth one now. Oh, here it is. Uh, this was just built at the University of Louisiana Monroe. It's an osteopathic hospital, but it's the first of what I think will probably be more than one osteopathic medical schools in Louisiana. But this was built on campus at University of Louisiana Monroe. The ACA in hospitals, there were some changes. One of the big things was physician-owned hospitals could not be expanded, and there would be no new physician-owned hospitals. And the point was to disincentivize physicians to own hospitals and therefore potentially enrich themselves by having people admitted to their hospitals. And these are words that I've talked about before: licensure, certification, and accreditation. License issued by the state. Every hospital has to have a license. These are some of the conditions that go with that. Certification. Certification is issued by Medicare. To be able to take payment from Medicare, my hospital has to be certified by Medicare as a participating provider. There will be other things that I talk about, such as EMTALA. All are based around conditions of participation through your Medicare certification. And then the other one is accreditation. So those three pieces all apply. You've got to be licensed, you have to be certified, and you have to be accredited. Now, if you're a VA hospital, as an example, you only have to be licensed by the state and accredited. You do not have to be certified because the VA doesn't bill Medicare and Medicaid, so they don't have to be a participating provider and therefore don't need to be certified. But most hospitals need to be licensed, certified, and accredited. And the accreditation is, again, the Joint Commission is the most common accrediting body. There are some other accrediting bodies, but the Joint Commission is the one most commonly seen and pursued. So as I've mentioned before, the hospital board of trustees is the governing body. Now they hire someone to oversee some of the day-to-day activities, the company's performance, and that's the CEO. But the board of trustees is ultimately responsible. And then the medical staff is that group of licensed physicians that you have to have to provide medical care, admit patients, and discharge patients from your hospital. Let's kind of rotate now to home health. What is home health? Home health has really expanded a great deal, and the aim of home health is to, again, create a better transition so that when people leave the hospital, they can go home and still receive continuing care, particularly physical therapy and occupational therapy, PT and OT, and then some other things that they may need at home. And a part of electronic diagnostics will help us extend to home health things that we see for their future. Home health providers includes nurses, social workers, home health aides. To a lesser extent, some of these like physicians, psychologists, a lot of that in the home health setting is being done with telemedicine. Obviously with a dentist, you can't do that with telemedicine. You can't do most of that with telemedicine anyway. So in some of these cases, either the physician needs to go to them, or most of the time, those people need to go to the physician. Sometimes that is something like a Medicab, which is a smaller type vehicle, similar to an ambulance, but not quite as well equipped and well trained as an ambulance crew. Other types of diagnostic equipment. Also note that I use the acronym EKG, and and it's commonly noted as an EKG, but it's technically an ECG. That's an electrocardiogram. That's the electronic tracing of the heart. Other home health care services, again, the telemedicine monitoring is really huge now, particularly with the pandemic. Hospice is another part of this in terms of allowing people to stay at home and be around friends and to die with dignity. It is important to recognize that home health is not a new novel idea. This really came about in the 40s and 50s, and the whole aim was to help people, again, stay in their home as much as they could. And actually, we can go back to the early 1800s when physicians went to people's homes and provided care in their home. There was not a lot of hospitals in the early 1800s, that early 19th century, because people didn't go to the hospital. They stayed at home, and somebody went to fetch the doctor, and the doctor came to your home and took care of you in your bed in your home. It was only when you were away from home that you really needed a hospital, and that's why we saw, hospitals associated with the American Civil War. We saw hospitals actually associated with the Revolutionary War and the War of 1812. But we also saw hospitals at ports where sailors were away from home. And so the whole aim to building hospitals really wasn't about taking care of people in the local community nearly as much as it was people who, again, couldn't receive care in their home. And so what we've seen really for 200 years, up until the 1950s, 1960s, with the explosion of hospitals, was, again, people staying in their home to some extent, and either the nurse or the doctor coming to their home. Again, the shifting care, this is one of the earlier views of what charity hospital looked like. Again, by the 1930s, some of the Visiting Nurse Association, hospital referrals, Medicare expanded home health in the Part A stay. It also covered more chronic care under the Part B benefit. Just some other aspects of Medicare and home health through the Omnibus Reconciliation Act of 1980. Remember, in 1981 particularly was when the DRG was implemented. There was the point to the 1980s was to look for ways to, Medicare in the 1970s was a cost that was spiraling out of control quickly. So a part of this was to look for ways to help control some of that cost. What else do I want to say here? The 1997 Balanced Budget Act did dramatically change home health care. Earlier I mentioned the Hospital Corporation of America. Columbia HCA was one of the largest employers on the planet, top 10 in the world, and they owned over 300 hospitals. In 1997, they also owned the largest home health agency in the United States. By the year 2000, they moved from the largest provider of home health service to zero. Closed all of them, sold them off, spun them off. Why would they do something like that? Well, the Balanced Budget Act of 1997 made it really less profitable to provide home health. And after a while, HCA did the math and said, you know what, our core business is hospitals, and we're going to get out of this and sell it or give it away to people who maybe they can do a better job with it than we did. There were a lot of home health agencies that went bankrupt between 1997 and 2001, which was the phase in of the impact of BBA 97. Let's see, so prospective payment also a part of BBA 97 as it relates to home health. let's see, what else do I want to be sure and talk about with home health? There are some definitions here about homebound. That is important because it creates that definition of medical necessity, who can be eligible for these types of care or the type of care available, what skilled nursing is and skilled care that's available. Again, under the Part A requirement for hospice, skilled nursing, and home health care. And remember, skilled nursing is 20 days of full payment, and then another 80 days of partial payment, and after 100 days, there's no skilled nursing benefit under Medicare Part A. What else do we want to talk about here? Yeah, we've talked about the 4 parts of Medicare. The other aspect I do want to be sure and talk about in terms of Medicare and home equipment. So this is Medicare Part B, and we're really talking about something called DME, durable medical equipment. And with DME, we're talking about commodes and wheelchairs and walkers. What are the things that you need in your home that you probably don't have to help you leave the hospital and go home? Again, it's cheaper for us as a country to typically buy some of those things for you through the Medicare program than for you to stay in the hospital for another week. Those walkers and wheelchairs aren't terribly expensive compared to inpatient hospital stays. Nothing is more expensive, generally speaking, than inpatient hospital stays. So what else do we want to talk about here? So let's go ahead and make the flip into emergency medical service. What is emergency medical service? Again, it primarily is a system that's used to coordinate the delivery of emergency medical care when you dial 911. Who comes? What type of services can they provide? What type of training do they have? What type of equipment do they have? And this system really grew out of a 1966 research paper produced by the Department of Transportation, NHTSA. It's called Accidental Death and Disability, the Neglected Disease. And it basically reported in 1965, more people died on the highways just that year than in all of the Vietnam War conflict for the first 4 years of the war. And the whole point of that was to remind us that we structurally had some huge problems in dealing with vehicle accidents. The people weren't trained, the ambulances were poorly equipped, they were typically associated with funeral homes, there was no common phone number to call. 911 didn't exist at the time. If you got to the hospital, most hospitals didn't have a doctor working in the hospital 24 hours a day, 7 days a week. They would have to call somebody in from home or from their office. It's safe to say it was not set up for you to, most of the system was not designed for you to be in a vehicle accident and need emergency medical care. Actually, I need to pause just a moment and answer a phone call here. Okay, I'm back. So actually my camera looks like it's way out of focus. Hang on, let me. Okay, so I think I've got the camera situation taken care of now. So again, let's kind of move on to this slide. So we do primarily have a tiered response. There may be medical first responders who are the first ones on the scene. In some cases, it's law enforcement. In some cases, it's fire department, first responders. There's often a lot of confusion about, I dial 911, I wanted the ambulance to come, why did the fireman show up? It's usually because fire departments are more widely distributed, and more capable of arriving at your home faster than EMS. And so in many cases, they may arrive first and they have some basic medical equipment. They can help us find it. They can provide additional manpower, and they can provide additional life-saving care until the paramedics arrive. And then the aim with this, again, kind of a tiered response, is paramedics are then able to arrive and provide, again, that life-saving care that's needed, usually within 10 minutes of dialing 911. And the whole aim behind this is to take emergency care to the scene and provide that type of life-saving care, and then again continue the provision of that care onto the hospital. One piece, in terms of the history, if we go back to the Bible, we read the story of the Good Samaritan, and the whole aim to that was to remind us that care has been provided in many ways throughout the years. We've just not called it EMS only until the last 50 years or so. And it's only become a comprehensive system only in about the last 50 years. But even if we go back, again, 250 years, Napoleon was really the first military leader to understand, actually to replicate some of the things that were done during Roman times in terms of recognizing the importance of providing care, or at least rapidly moving soldiers that had been injured in battle, so that they could return to the battlefield. In terms of how we see this care and how things have changed, to some extent that's also occurred here. If we look at this image of the ambulance building for Charity Hospital from the late 1800s, even before the automobile, we were still providing some type of ambulance service. Here's another image of an ambulance in the 1920s. But again, there was some type of ambulance service that was available. It just was far less organized, and certainly did not include the type of comprehensive care that's available today by most any of the EMS systems, such as New Orleans EMS. And there, certain parts of the country, there are volunteer rescue squads that didn't have a lot of paid people that provided maybe fire service or EMS, or were a part of a hospital. This particular volunteer rescue squad was actually one of the first organized rescue squads in the country. But it gives you an idea of the type of equipment they had available. Here in the 50s, there was, again, this kind of gives you an idea of just how things have changed and how much has changed. Ambulances being a fast ride to the hospital, and really that's kind of all they were, with oxygen and two-way radio communication. And then again, this gives you a little bit more of the imagery of what we saw with medical care from the 1700s to the 1800s. The first defibrillator, this is a device that we put on your chest to shock your heart, to restore the electrical activity in your heart. Obviously, the defibrillators today don't look anything like that. But the big picture is, if your heart electrically is not working correctly, we do need a defibrillator, or we may need a defibrillator. If it's not causing a pulsatile rhythm, meaning I can check a pulse and I'm alive and awake and alert, and instead the electrical activity in my heart is quivering, ventricular fibrillation, I've got to shock that rhythm if there's any chance of returning you to a spontaneous pulse and respiration. And this is just a little bit more of the timeline. I do want to move forward to 1968, which is AT&T identified an area code that was not being used, and that was 911. And so that's really how we developed a 911 system here in the United States. Actually, the very first 911 was in a rural community in Alabama. I may have a picture of that in a minute. A lot of this also, and this gets back to the accidental death and disability, the neglected disease of modern society, was really helping us understand that we were doing a terrible job of providing emergency medical care for people who had been in vehicle collisions. Really no standards, no training consistency, equipment just wasn't there. And so this led to the Traffic Safety Act of 1966, EMS Systems Act of 73, and EMS for Children in 84. These three pieces kind of flowed together to create the framework of what needed to be done nationwide for healthcare. But the one thing that really changed things in a really dramatic way was a TV program that was produced and started debuting January of 1972 called Emergency. It highlighted two fire department-based paramedics based in Los Angeles County, and the perception of most of the public was, well, we must have that. And when they realized there were very few paramedics in 1972. In fact, I was one of the first 100 paramedics in North Carolina, and that was in 1980. And they were, you know, I would be surprised if there were 100 people who had the certification of paramedic in Louisiana in 1980. I mean, it took a while for these programs to take off. It took a while for people to recognize what needed to be done to create the programs, and all of the training and all of the equipment that needed to be purchased, and how much needed to change. So there was a gap between what the public perceived they had and what they actually have. But the reality was a TV show probably did more for that than most anything else that was done at that time or could have been done since that time. And then different types of certification. The most common is the EMT Basic. It's about a 100-hour program that teaches you a little bit more than complicated first aid, obstetrics, how to use oxygen, how to immobilize fractures, really basic life-saving skills. And then the most complicated of those are the paramedics. And paramedics typically train for about 14 months of intense training as it relates specifically to emergency care, pharmacology, electrophysiology, cardiac care, things that are important to save someone's life. Anyway, that's some of the training specifically targeted to paramedics. So that's the first responder program and the basic EMT. Again, most people in a fire department who are first responders have some type of a basic EMT, emergency medical technician, or a first responder type training. The intermediate is a skill set that's somewhat in between an EMT and a paramedic. There's a handful of advanced things they can do to be a little bit more helpful to the paramedic on the call. And then this is really the gold standard, the paramedic. But there are not a lot of paramedics, and so sometimes you may see ambulances with only one, sometimes they have two, but the reality is this is the person that has the greatest amount of training and the greatest expertise to provide the care. And we're back to the star of life, and let's kind of conclude with this. So this is really an overview of all of the things that have evolved through the years, from really the pest house and the almshouse to what a hospital is, critical access hospital, reinforcing the things we've talked about before with a license, a certification, and accreditation, and then talking a little bit about home health and emergency medical service. So this is kind of a wide-ranging presentation, but hopefully it at least gives you a few more things that reinforces things you've heard before and some new pieces of information to add to what you didn't know before today. Anyway, I hope that was helpful, and I will see you next Monday night in class. But until that time, let's wrap it up. You have a good day.